For that kind introduction, Bert. Um, so thanks for having me here. I'm excited to tell you a little bit about some of the research that my group has been working on. And I think broadly, my group has kind of two research threads, and these are methods development for general machine learning methodology. And then we also have this domain specific interests in neonatal perinatal medicine. Um, and so today, I'm going to sort of focus on the second thread here. I'm going to walk you through some of the neonatal perinatal projects we've been working on. And there's going to be an ulterior motive for this talk too, is I'm going to try and convince you, if you're not already convinced, that the neonatal intensive care unit is this really interesting place to do machine learning and I think generally quantitative kinds of methodological research. So there's going to be a little bit of a subtle argument that I'm trying to make here, and hopefully by the end you'll be convinced. So I think also too, I'm going to take you down some rabbit holes. So in my introduction, Bert kind of hinted at the sort of eclectic background that I have academically. I was originally trained as a computer scientist and then went to grad school in statistics, and now I'm a professor in an epidemiology department. And I think that speaks to I like to follow interesting problems, and those problems may or may not be prescribed as machine learning. But if it's an interesting question, I think that's the most important thing. And some of the projects that I'm going to talk about today were not things that I anticipated working on, but sort of came up in the process of thinking about machine learning. And so I'm going to sort of take you down some of those rabbit holes. Just as sort of an advertisement for some of the work that unfortunately I won't have time to cover in depth today. My group does lots of, as I said, general machine learning methodology research, specifically on this class of machine learning models called self-supervised models. And this is, I think recently, ChatGPT has made folks very aware of what a self-supervised model is, and that's an area of focus for my group. A very strong area of interest for my group is causal inference. I sit in something called the Causal Lab here in the epidemiology department, and we think a lot about how to bring advancements in machine learning and deep learning to the causal inference literature, and we've written some papers with Miguel Hernan and Jamie Robbins sort of in that direction. Another thing that I spend a lot of time thinking about are medical AI safety guidelines. And so folks in an epi department are probably very familiar with things like Tripod and Spirit and Consort and all of these reporting guidelines if you're doing a clinical trial. And I've been involved with efforts to update those for the sort of unique aspects of AI as an intervention. And so I've been involved with a lot of the folks who have helped write the new guidelines for AI. And then finally, my group works on uncertainty quantification for black box machine learning models. And the way that I explain this to my clinical collaborators is we really want our algorithms to be able to say when they're not sure and be able to say, I don't know. So there's a very hard methodological challenge built into that because the types of models that we use in machine learning aren't often amenable to the same types of analysis that we would use if we were using traditional statistical models. So that's a very active area of research for us. Okay, so I'm going to walk you through a little bit of what goes on in this place called the Neonatal Intensive Care Unit, or the NICU, and then again try and convince you that it's a really fertile area to do various kinds of research. Before I do that, I would like to juxtapose the types of things that happen in the NICU with other things that have happened in medicine more broadly over the last 5 to 7 years. So over the last 5 to 7 years, we've seen rapid progress in the use of a specific kind of AI called deep learning in ophthalmology, dermatology, pathology, radiology, essentially anything that looks like diagnostic medical imaging. There has been a deep learning based AI system that can perform that task, with a lot of caveats, approximately as well as a human physician can do that task. So if the task is looking at an X-ray and deciding whether or not a patient has pneumonia, there has been a lot of progress in automating that kinds of things. Moreover, there has been FDA approval for these devices. And specifically, there are now FDA-approved AI systems that can render diagnostic information without the aid of a clinician. So a technician can wheel in a specific kind of medical device. They can scan your retina, for instance, and then give you a diagnosis of something called diabetic retinopathy with no physician required for that. And so that has been FDA approved. If you really want to get wonky, there are reimbursement models for that. So hospitals can actually bill for these autonomous medical AI systems. And I'm giving you this sort of context because it's not that medical AI is impossible. There have been lots of progress in other areas of medicine But what I want to show you is that the NICU actually has all of the same components that these other areas have, but is currently understudied, at least relative to things like adult areas of medicine. Okay, so the neonatal intensive care unit, or the NICU, primarily cares for preterm infants. So a preterm infant is any infant born before 37 weeks of gestation. The kind of rule of thumb that we all know is that 47 weeks is a full-term pregnancy. Neonatologists kind of walk that back a little bit and say any baby who's 37 weeks or older when they're born is a full-term infant. I always like to remind people that preterm birth is one of the most common forms of rare disease in the world and also in the US. So just statistically speaking, there's probably someone on this call who either has had a preterm infant themselves or knows someone who has had a preterm infant. Approximately 10% of infants born in the US are preterm. And so there's a sort of weird definition of what constitutes rare disease, but the preterm infants are actually one of the most common forms of rare disease globally. Often, sort of unsurprisingly, because these infants are born before they're done fully gestating, they're born at very low birth weights. And this can be extreme in some cases. So an infant born at 22 to 24 weeks may weigh fewer than 500 grams. If you go and see one of these infants in the NICU, they're sort of about the size of your hand. They would fit in the palm of your hand. They're just extremely tiny infants, and they have lots of complications. And as I mentioned, they're going to face a pretty challenging clinical course if they're born extremely preterm, and they can be in the NICU for 4 to 6 months. So this is going to be challenging not only for the infant itself, but also for the family supporting that infant. And there's just an enormous amount of social, emotional, and financial toll that happens as a result of preterm birth. A lot of the clinical complications that these patients face are direct consequences of being born too soon. They're just not ready to be ex utero when they're born, and a lot of the challenges they face are, as I said, a direct consequence of that. Their lungs are not yet well developed enough to breathe room air, so they're often intubated or given oxygen support. Their digestive tract may not be fully ready for feeding, so they often have feeding tubes as well. They have immature hearts, which can cause acute and chronic cardiac complications. And so what a neonatologist is often trying to do is maintain physiological stability so that the infant can grow and mature ex utero. So they kind of want to mimic what's going on in the womb in the NICU so that the infant can just grow and mature. And that's kind of the name of the game in neonatology, is keep the patient stable, keep them fed, and keep them growing. The etiology of preterm birth is very complex. There are many things that are believed to increase risk for preterm birth. Maternal age and health are known to affect risk for preterm birth. Socioeconomic status and race, again, are known to affect risk for preterm birth. There's a genetic basis for preterm birth, but the picture remains poorly understood. And so the figure that I'm showing you here is from a study that we did in 2017, where we took a large insurance database. We looked at all the maternal risk factors that were recorded in that database, and then looked at their association for risk of preterm birth. The y-axis here is the minus log 10 of a p-value for each risk factor. Each dot here is an individual risk factor. And then they're sort of grouped by systems. And so the brownish red ones here are endocrine or metabolic conditions. The red one here are cardiac. So this dot here, this high red dot here, is actually hypertension. So hypertension confers a large risk for preterm birth. But what you can see from this picture, even at a glance, is that it's a multi-system phenomenon. There's not one single system that's responsible for preterm birth risk. So it's a very complex, multifactorial kind of condition. In a previous study, we also looked at the economic consequences of preterm birth. Using an insurance database that I'll dive into later in the talk, we essentially just looked and calculated how the degree of prematurity, so how old were you in terms of gestational age when you were born, how did that affect how much the healthcare system spent on you for the first 6 months of life? So for the very preterm kids, the ones born at 24 weeks, the median expenditure was $500,000. So again, there's an enormous amount of healthcare resources being spent on these patients. And in some cases, those resources can be in excess of $1 million. So the financial toll, again, to the healthcare system is immense from preterm birth. It's not, like I said, it's not uncommon to see expenditures in excess of $2 million for these patients. Okay, so I see a question in chat. I might click on that and see if there's, I think maybe
Well, we do it afterwards, Annie. That's okay. We take them together. Yeah.
it's hard to turn off the inner teacher in me and not answer questions as we go, but we will hold them until the end.
Okay, but Don will wait. Don't worry.
Yeah. So now I'm going to give you an overview of what's been done in terms of machine learning in the NICU. And also, this is where I'm really going to try and lay out my philosophy or my argument for why I think that this is such a uniquely qualified area of medicine for machine learning. So here's a couple properties when I think about from first principles why the NICU is a good place to do machine learning. The very first things is that these babies have very dense medical records. By dense, I mean every day of their life, labs are taken. They have real-time monitoring data being generated in terms of oxygen saturation, heart rate, all of those kind of vital signs are recorded on a daily basis. Everything that the physician does to them is recorded. So if they receive a medication, if they receive some kind of procedure, that's logged in the electronic medical record. They get tons of imaging, X-ray data, retinal imaging data that I mentioned before. So they have all of the same types of data that have been used successfully in other areas of machine learning on a pretty regular basis. So they're very well characterized from a physiological perspective. They also have complete medical records. So in the EHR, when you were thinking about adult populations, or even in study data, someone shows up in your data at the age of 32, 45, 55, and you kind of have no information about what happened to them before that moment. NICU infants, that's not true. They're born and their medical records start, and you kind of have this complete picture of their entire life. And I can't think of another patient population that is so well characterized from the first day of life through the first, let's say, 3 to 6 months. It's just a very unique patient population and a very well characterized patient population. And so I mentioned they're also data rich. They have, from a methodological perspective, if you would like to develop methods for time series data, for imaging data, for text data, there's a NICU infants generate all that. So I think that it is a plethora of data that you have at your disposal, both to inform patient care, but also to develop new methods. I think this is also not appreciated too until you get closer to neonatology. The space of possible outcomes and possible actions in the NICU is much smaller than most other areas of medicines. Most neonatologists worry about a small handful of conditions, so between 5 and 7 things they're really thinking about and trying to manage. The number of treatment options is also reduced relative to adult populations. You don't have to think about things like non-compliance. If you give a NICU baby a medication, it takes that medication. They don't really have the option to be non-compliant. And so a lot of these things that we think about as being methodological challenges actually just don't exist in the NICU. And so depending on whether you're an epi researcher and want job security, that could either be a feature or a bug. But it is sort of just a simpler universe. And again, I think that it's also easy to lose sight of this, but important to keep in mind. If you move the needle a little bit in these patients, those positive changes propagate out through the rest of their life. If you can improve their lung health just a little bit during this very vulnerable window of their life, they may not have asthma as an adult. So you really do have the ability to move the needle in these patients, again, in a way that's very rare in other areas of medicine. So this is just a picture of what a NICU isolate looks like. This is obviously not a real baby for HIPAA reasons. This is a doll in an isolate. All of the arrows that I'm showing you here are potential things that generate data about this patient. So again, it's just a sort of an embarrassment of riches when it comes to the kinds and the amount of data that you have for a single patient. So I'm going to give you a small taste of this today, but the big picture for what my group is working on is to take all of the projects that I had on the second slide of this talk and tie them together into some type of holistic multimodal data integration model that can take in all of these streams of data and help neonatologists reason about their patients and make better decisions. So the sort of long-term vision of what we're trying to do is take all of these things that look like individual projects, from self-supervised learning, from causal inference, from the imaging models, put them all together under a common umbrella and have a comprehensive model that can really help inform clinical care. So, people always ask, why am I interested in the NICU? I think the honest answer is that I come by it naturally. My wife is a neonatologist at BIDMC here in Boston. And you can only go to dinner with someone so many times and hear them talk about the challenges in their own discipline before you start to see opportunities. And so I think that that's kind of been a two-way street for me. I've become convinced that the NICU is this unique place. And likewise, she's become convinced about that AI can actually solve some of the problems that they're working on in neonatology. And then the other, I think, glib answer is that it was easier than getting an MD PhD myself. We were able to parallelize some of the knowledge acquisition in working in this area, and she can handle the clinical things, and I can sort of handle the methods things. So I sort of at the beginning alluded to the fact that we have not seen as much progress in the NICU in terms of AI advancements as we have in other areas. What I would not want you to think is that there has been no machine learning done in the NICU. There actually has been quite a bit. The most notable is a sepsis risk prediction model called HERO that's actually commercially available and used in lots of different NICUs across the country. There are lots of things that are traditionally called risk calculators, and these are things that you put in a small number of clinical variables, and it will give you a risk score for your patient for an outcome. They're used with varying amounts of adoption. And then there are ROP screening. So the advancements in adult diabetic retinopathy screening from retinal imaging have also been translated into the NICU. So that I think is a good example of the type of advancement that I'm advocating for here. And again, one more hors d'oeuvre sampler before we move on to the main course here. I just want to give you an overview of some of the NICU projects that we're working on. So we're working with some researchers at Boston Children's, Duke, and UNC to develop pulmonary hypertension screening on echocardiogram using deep learning. We're trying to develop a non-invasive way to measure laboratory values from these patients. So actually taking blood from them comes with non-trivial risk. We're using visible light spectroscopy to try and do that transdermally so that you can get real-time monitoring of patients' laboratory measurements without actually having to draw blood. And then one of the things that I see Michael Smith is on the call, who's a grad student in my group, is working on is looking at using observational data to come up with optimal timing for steroid doses for infants who are at risk for something called bronchopulmonary dysplasia. And again, I'll talk on that a little bit at the end. And that's much more in the causal inference vein of the research going on in the group. Okay, so recall at the beginning, the whole problem with preterm infants, the main challenge is that they were born too soon. And so we're trying to simulate this ex utero womb. So one solution, actually, the straightforward, I think of it as kind of the end game for neonatology, is to create an artificial womb. And that closely mimics a real womb as possible. And so researchers at CHOP are actually doing this. And so, at least in my assessment, this is one of the more promising ways to holistically treat a lot of preterm birth ailments, is to have an artificial womb that you can transfer the patient into and have them continue to develop and gestate ex utero. This is a lamb model of preterm birth that the researchers at CHOP are using, and they have some early promising results. But I think we are still quite a ways away from this being a realistic clinical resource that we can use. I think once you think about that, the next most obvious thing is, can we find a drug that we can give the birthing parent to reduce the risk of preterm birth? Is there something that we can give them that would keep the baby sort of in there as long as possible? So it turns out there's exactly one drug that is thought that can do that, and it's called Makena, or it's called 17P, and I'll sort of refer to them interchangeably, but give you a little sense of what the difference between 17P and Makena is as we go. So 17P, or Makena, is the only drug that was believed to reduce risk of preterm birth, but the story is very complicated. So it's a shot that you can get. It's an injectable synthetic progestin. It originally showed effectiveness for preventing recurrent preterm birth in a trial done by the NICHD in 2003. For a long time, it was widely available as a low-cost compounded drug. So your doctor could prescribe it. The local compounding facility would make it kind of order, and you would get it. However, in 2011, a company called KV Pharmaceuticals received an orphan drug designation for 17P, and then started to sell it as this branded version known as Makena. So unfortunately, this move to the branded version of 17P, known as McKenna, resulted in a massive price increase. And so there was a lot of consternation expressed by the MFM community when this happened. However, the drug manufacturer kind of refused to disclose exactly how much they were charging for this drug. So during my postdoc, I actually had access to a database of insurance claims. So I knew how much people were actually paying for this drug, or at least how much the insurance company was being billed. This was an enormous database of 45 million patients. And so we decided to actually look at this question for ourselves. How much, what is the price difference between the sort of generic 17P version of the drug and the branded version of McKenna? I'm just going to give you a quick rundown of how claims data are generated. If you're used to working with cohort data or data explicitly created for research, this is going to be a very different kind of data. And I'd just like to give you a flavor of that before talking about the results. So imagine that this is John. John has a heart attack and goes to the hospital. After John is cared for at the hospital is going to generate something called a claim that has essentially 4 pieces of information: his name, the date, a code, and then an amount. And the code tells the insurance company what services John received while he was at the hospital. So in this case, he received a code of 410.01, which is acute myocardial infarction or heart attack. And then he received this code, 37.21, that tells the insurance company that he had a right heart cardiac catheterization. So they cathed him. So in total, John received $6,000 worth of healthcare services at the hospital. Excuse me. So this is a claim that's generated every time you interact with the healthcare system. And after it's generated, it's sent to the insurance company. The insurance company is going to look at this and either approve it and say that looks good, or they're going to deny it and send it back to the hospital and say, try again. We actually think, based on the claim that you submitted, John only received $3,500 of healthcare services. But this table in the middle is what people refer to as claims data, and it's the kind of data that I'm going to use in the next couple of studies. So important to keep in mind that in claims data, what we actually observe is negotiation between the hospital and the insurer. So the whole reason claims data exists is to justify a reimbursement. It is fundamentally a receipt. It is what the hospital sends to the insurer in order to be reimbursed for the services they provided. All of the data that you see in there are procedure diagnosis and procedure codes used to justify the amount that was requested. And you also, importantly for our study, you get to see prescriptions if the patient also has pharmacy coverage to the same insurer. So essentially, it's like a ledger. It's the ledger that the insurer is actually keeping so that they can keep track of how much they were billed and then how much they paid. So I think a very reasonable question to ask if you're used to using high quality research data is, why would anyone want to analyze a bunch of receipts? So there actually are some benefits to this. Is that, first and foremost, is that it's huge. Especially, the database that we're using here covered 45 million individuals. It's routinely collected, and so it's also comprehensive. So if you think about what normally happens with EHR data, if I go to urgent care that's outside of my hospital network, that does not show up in my electronic medical records. Or there are these sort of systematic blind spots in traditional healthcare data that don't exist in claims data, because at least in the US, if someone pays for it, it generates a claim. The cons is that it can be extremely biased. Again, the reason this data exists is because someone wants to get paid. And so those types of incentives leads to certain kinds of biases. It's collected to optimize billing. It's very coarse also. So we typically don't have good laboratory data. We don't have note data. So we don't have very fine-grained information about what's going on. And so it's actually not great for a lot of questions. In a different version of this talk, I talk about a question that actually failed, that you couldn't ask of this data, even though we had hoped that you'd be able to. So you have to be very strategic in the kinds of questions that you ask. This data is not capable of answering all questions you might want to ask of it. Okay, back to the 17P story. So again, through this partnership with an insurance company who gave us access to their claims data, we wanted to look and try and answer this question of what was the price differential for 17P. We had 9 years of claims data from 2008 to 2017, covered 45 million people, 5 terabytes of data, 9.8 billion diagnoses, and 4.4 billion procedures. So the inclusion criteria for the study were very straightforward. Women with medical and pharmacy coverage through the insurer were included. You had to have a singleton pregnancy. So this is an indication criteria for the drug. You can only get this drug if you have a history of preterm birth and you're currently carrying a singleton. And you had to receive a prescription for either compounded 17P or McKenna. And then the outcomes we looked at, again, were very straightforward. They were medication costs, preterm birth rate, and infections. So here's the punchline. We saw a 5,200% increase in the cost of branded 17P, aka McKenna, versus the original unbranded formulation. So $11,000 on average per pregnancy for McKenna, and then $200 on average per pregnancy for the compounded, or generic version of the drug. So we saw no differences in the rate of preterm birth between the two groups, and no difference in adverse events. So the conclusion from this study, which we published in 2017, was the expensive form of the drug doesn't seem worth it. It seems certainly that there's not a lot of benefit being added for what is a dramatic increase in the cost. So I mentioned that the original evidence for this study came from a 2003 trial from the NICHD. However, this trial has been widely criticized since as being abnormal. Specifically, the rate of recurrent preterm birth in the control arm, the untreated arm, was 55%. That's more than double what you would expect it to be in sort of the general population. So for whatever reason, the patients in the control arm of the original study were experiencing preterm birth rate at twice the rate that you would expect. And so this made the drug look like it had a benefit. Again, the rate of recurrent preterm birth in the treated group was 36%, which is still pretty high. But anytime you're comparing to a control arm that has that rate of preterm birth, you're more than likely going to find an effect. And again, many lines of evidence have since failed to support the result of this initial trial. It was one of the big, outstanding, open questions in maternal fetal medicine. And so we were wondering, given that we had this data, could we look at this and determine, help add another piece of evidence about if this drug actually worked? So we used some ideas that were developed here in the department, specifically something called a target trial, to go and estimate the causal effect of this drug using observational data. So our target trial followed the exact same protocol as the published RCTs of this drug. We used the same inclusion criteria, the same time zero, again, as the published RCTs. And then we matched treated individuals to untreated controls, women who were eligible to receive this drug but didn't, using propensity score matching. And the short version of the conclusion is we found no evidence of benefit for this drug in this population. The risk ratio is 1.1. The confidence interval went from 0.9 to 0.135. And these conclusions were robust to a comprehensive sensitivity analysis. So no matter how hard we looked, we were unable to find any evidence of benefit of this drug in this data and in this cohort. And this was published in the Journal of Perinatology in 2021. So this story actually continues to be updated. So after we published our study, the FDA convened a panel and synthesized all of the evidence for 17P and actually recommended pulling the preterm birth drug from the market. This is a figure from the CEDAR report filed by the FDA. So you can see this is a visualization of all of the effects from the original trial here on top. And then they cited our study as one of the key pieces of evidence in their recommendation to remove this drug from the market. And you can see lots of the other studies done on 17P are consistent with the null of no effect. As I was updating my slides today, another story came out about this drug. So today, March 8th, 2023, the maker of McKenna is withdrawing it from the market. So they have decided to no longer sell this drug, citing the lack of evidence of benefit for patients. If you go and read the article that came out in the New York Times, they will actually say that they think the risk-benefit ratio is still favorable, but they are no longer going to sell McKenna going forward. Okay, so I'm going to stop here, just take a sip of water. And if you have questions, like Bert said, I'm happy to answer them at the end. So that line of research, I think, is a good example of a rabbit hole. I did not go into those projects necessarily trying to think about 17P. I went into it actually wanting to predict preterm birth. And the slide that I showed that had all of the risk factors was some work in that direction. But as I started talking to my MFM colleagues, they really, once they saw the data that we were analyzing, really, really wanted more information about whether or not 17p worked. And so we listened to them and sort of ended up studying that instead of building yet another ML model. So I'm going to shift gears now and talk about some actual machine learning and how we are going to predict something called bronchopulmonary dysplasia using deep learning. So bronchopulmonary dysplasia, or BPD, is a form of chronic lung disease in preterm infants. So if you assume if the infant makes it to discharge, if they survive the first couple weeks of life and they're actually going to go home, BPD is actually the central challenge in the NICU. It becomes the thing that the neonatologists are trying to manage and trying to reduce. The definition of BPD has changed over time, but the current definition is that an infant requires oxygen support at 36 weeks post-menstrual age, they have BPD. Said another way is if you're still on oxygen at the time you were supposed to be born, you have something called BPD. I sort of like to go at my neonatal colleagues here and remind them that that's actually not a disease definition. That's a definition of treatment. It's kind of like saying you have cancer because you're on chemo. It doesn't tell you about the underlying disease pathology. It doesn't tell you sort of anything about mechanism. It's just a definition of treatment. But as of today, the definition of BPD is that if you're on oxygen, at the time you were supposed to be born, meaning 36 weeks post-menstrual age, then you have this thing called BPD. However, again, if you're thinking, about this, that there's this temporality built into the definition of BPD. So when a baby's born, I cannot diagnose them with BPD. I have to wait into the future to see if they're going to be able to come off oxygen. So if I had some kind of crystal ball that told me who was going to go on to have BPD and who wasn't, it would change the way I would manage that patient. So I might be more willing to aggressively start steroids earlier if I knew this baby was at high risk for, having BPD 3 months in the future. And so predicting which babies are going to go on to have BPD is actually a very active area of research and actually a very clinically important one. Just to give you a sense of the epidemiology of BPD, approximately 10,000 to 15,000 infants annually get BPD. If you're born at less than 1,000 grams, less than 1 kilogram, about half of those babies get BPD. And increased severity of BPD, so BPD is a graded disease, is associated with worse outcomes. So you have increased neurodevelopmental impairment. That may be a side effect of the treatment in some instances, which are steroids. You're often likely to be rehospitalized with pulmonary cases. So like I said, these kids may go on to have asthma, and that you will be using respiratory meds for a while after you're born. And so lots of therapies exist to reduce other preterm morbidities, but BPD is actually rising. And so the incidence of BPD is actually going up. And again, it's one of the central challenges in neonatology. This is a table from the cost paper I mentioned that we wrote at the beginning of the talk. And we looked at how these different NICU diagnoses affect healthcare spending. And so the one that affects it the most is BPD. So on average, if you get a diagnosis of bronchopulmonary dysplasia, the amount spent on you by the healthcare system doubles. So not only is there, increased morbidity associated with getting BPD, but again, there's this force exerted on the healthcare system financially by BPD. So I mentioned it would be great if we had a crystal ball that would tell us who to treat and who not to treat, or who's likely to get BPD and who's likely not to get BPD. So I was fortunate to be approached several years ago by some neonatologists at a group called Pediatrics. And Pediatrics is a group of 300 private practice NICUs in the United States. And they told me about this amazing data set they had of approximately 60,000 preterm infants across their 300 NICUs that are very richly characterized in their sort of homegrown EHR. So they record a lot of things in the NICU that traditional systems like Epic and Cerner don't record. And they've created this specifically for research purposes. So the project that we came up with was, can we use this cohort to predict the severity of BPD across all 300 sites in this data set? So here's a brief summary of the pediatrics cohort. So they are infants born at one of the 300 pediatrics NICUs in the US. In total, there were just under 62,000 infants. They were born between 2009 and 2019, and they were born at or before 30 weeks of gestational age. and they were free of congenital anomalies. So that essentially is almost all babies who were born at a pediatric SNICU at 30 weeks or younger. And so the goal was to predict BPD grade and the competing outcome of mortality at discharge. So we're going to take their entire longitudinal record and try and predict who's got what type of BPD each infant is going to go on to get, or if they are going to survive to discharge. So as I mentioned, BPD is a graded disease. And so the outcome that we were predicting has 5 different levels. The first is no BPD. The first is called grade 1 or mild BPD, and that means that you're on a regular nasal cannula or hood cannula or hood oxygen at 36 weeks PMA. Grade 2 is moderate BPD, and that means you're on high flow nasal cannula or CPAP. And then grade 3 or severe BPD means that you're ventilated and that you have an endotracheal tube helping you breathe. And then the last level of this outcome that we're trying to predict is the competing outcome of mortality, because if you die before 36 weeks PMA, you cannot get a diagnosis of BPD. And so here was what I started getting excited about when I saw this data, is that it really is almost all of the data, except for imaging, that's collected on these patients. And so there are 800 total possible variables that are recorded, and they're recorded daily. And so we had daily cultures, daily weights of the baby, daily medications, daily oxygen support type, the demographics, both maternal and fetal demographics, procedures. So again, what the physicians were doing to the babies, and labs. And so we really have this comprehensive view of what's going on with these patients. And just from a study design perspective, we took this data set and divided it into 3 pieces. One was a training data set used to train the model of about 41,000 patients. Then we had an internal validation data set, and this was 10,000 patients from the same 53 facilities as the babies in the training data. So we sort of split all the data up by the center level. So we want to be able to see if the model developed at some centers can generalize to centers that it hasn't seen before. And that's what the external validation data set helps us measure. It's 12,000 patients from a different set of 65 NICUs. So the results that I'm going to show are the accuracy of the model on 65 NICUs that were not included in the training data. So we built a novel deep learning model based on a transformer architecture. ChatGPT is doing me some favors here, because the model behind ChatGPT is called a transformer. And we used that as our base architecture. We didn't use ChatGPT, just to be clear. We used essentially the same primordial ingredients that go into ChatGPT and trained it on this data, but it's the same kind of architecture that powers ChatGPT. If you've never heard of a transformer, I think it's worth thinking about it if you have longitudinal data, because it comes with several benefits. The first is that it's very flexible. I think this is what most people think of when they think of machine learning, is that you can learn nonlinearities, you can learn variable interactions, that it's this very flexible class of models, and that's true. But I think for this purpose, it's actually more important that it can naturally handle sequential or longitudinal data. So the transformer is able to take in everything that was measured about a baby on a given day of life, incorporate that into their entire medical history to update its prediction on each day of life. So it's not like we had to beforehand say, we're going to just take in the first 7 days of life and make a prediction. We can actually do it sequentially with each day of life. The model will give us a prediction about what's going to happen to the babies. And so the model will get better over time, as you can imagine. As it has more information, it's able to update its procedures, but it's a very flexible longitudinal class of models. And it's also very scalable. So I think by most standards, this is a pretty large data set. It would be hard to train comparable models on this amount of data. But again, transformers and the types of computer hardware that we can use to train these models make them able to scale to this size of data. So here's the result in a nutshell. Our model achieved an AUC of 0.87, or a C statistic of 0.87 on the first day of life. And then by day 28 of life, it's reaching an AUC of 0.95. Previous models in the literature, just to help you calibrate, range between 0.67 or 0.6 and 0.7 on the first day of life, and only reach an AUC of 0.85 by day 28 of life. So this is a pretty nice advancement over what's been in the literature. The figure that I'm showing you here is the transformer model shown in blue. The y-axis is the AUC. The x-axis is the day of life. And then the green and red models are standard statistical prediction models, a random forest and a logistic regression model. And you can see it's not just the data that's explaining the bump in performance here, because these models don't do as well. It really is the transformer itself that's also driving a lot of the boost in performance. And so, to our knowledge, this is the most accurate BPD prediction model so far. And I think in some instances, or in some ways, it's probably a good estimate for how predictable BPD is with routinely collected data. It's hard to imagine having more data or having more patients or having more variables is going to bump this up much beyond what we're seeing here. So I think that we're kind of at the limit of prediction for BPD in this case. Here's what the clinical trajectories that come out of this model look like. So here I'm showing you the trajectory for a baby that ends up not getting BPD at all. And so the red line here is the risk of BPD. The blue line here is the probability of no BPD. The y-axis here is the probability for each one of these outcomes. And then the green line is the mortality risk. And so you can see that the baby actually starts out at very high risk for BPD, but once they make it past day 10, the model thinks that they're sort of on a better trajectory towards not having BPD. Likewise here in panel C, this baby unfortunately starts out at high risk for BPD, but then something happens, on their second day of life that flips the predictions, and now this baby is at high risk for mortality and not surviving to discharge. And indeed, this baby did not survive until discharge. I think in the interest of time, I'm going to hop ahead to the conclusions because I want to leave some time for questions. But just to wrap up this section, I think, like I said, our transformer has the highest prediction accuracy of any model published to date. And I think that further improvements for this type of activity or this type of prediction are only going to come with additional data types, imaging, real-time monitoring data, and I think also with a refined BPD definition. I mentioned that it's kind of this very coarse definition of treatment, not of disease, and that we're actually working with the pediatrics folks to see if we can get this implemented and live in their EHR system for real-time decision support. So just to sum up, I hope that I've given you a taste of what my group's been working on, and also a sense of the opportunity for quantitative research, not just machine learning research in the NICU. There are publicly available NICU data sets that you can actually analyze if you find this interesting. Again, I think the future looks like lots of a single model that can take in lots of different data streams and help clinicians reason about their patients. And I'll stop there, and I'm happy to answer questions.